Our speaker today is back from last week is Dr. Laura Stinson. She's an academic detailing pharmacist working for the Healing Community Study. She also has a background in community pharmacy. And so yes, welcome back, Dr. Laura Stinson.
Thank you, John. So again, no financial relationships to disclose related to the content of this activity. And I'll just review the practice gaps and learning objectives from the last time. So like we talked about last week, the rate of smoking is much higher in patients with opioid use disorder compared to the general population, and this places patients at great risk. And many of these individuals are not being offered treatment for tobacco use. So last time we talked about the rate and risk of co-use of tobacco and opioids, some of the medications that are available to help with smoking cessation, and some behavioral interventions. And we talked about the relationship between nicotine and opioids and some of the barriers that are unique to individuals with opioid use disorder when it comes to smoking cessation. So again, hopefully you all will feel a little more comfortable talking to patients about their tobacco use, and you'll understand the differences between tobacco use in the general population, how that is different from patients who use opioids or have opioid use disorder, and then think about the barriers and possibly ways to overcome those for these patients. So I'm going to do this a little bit different than some of the other Q&A sessions. So instead of kind of doing a little review at the beginning and then going into the questions, I'm going to mix it in. So I'll do a couple of slides that were from last week just to kind of refresh our memories about some things that we talked about, and then put in a couple of discussion questions and hopefully get some feedback from you all so you don't have to listen to me talk the whole time. And then I've got a few poll questions and then some questions that did come in from the audience from last time. And before we start, I thought this might make people feel a little more comfortable with asking questions. I just got a call from my 8th grade daughter who is out buying school supplies, and she said that she couldn't find a 1-inch binder. That was one of the things on her list. She was really kind of stressed out. I can't find 1-inch binders. She said they have some really small binders, but I don't think they're 1 inch. So I thought, what in the world is she talking about? She thought she needed like a 1-inch binder, like this size. So I had to explain to her, it's the size of like what the book spine would be. They have 1 inch, 2 inch, 3 inch, and it's going to have that information on the product. So ask somebody in the store if you can't find anybody to help you. She's with her grandparents, but I was really glad that she felt comfortable enough to ask me that question and didn't spend a whole lot of time looking for a binder this big. Anyway, so I hope everyone feels a little more comfortable answering questions after hearing that. Okay, so to review a little bit from last week, there are still a lot of people in the United States that smoke. So it's gone down in the past few years. So in 2005, it was a little over 20%, and then has dropped to 14% in 2019, but that still means that over 34 million adults in the United States smoke. So for patients with opioid use disorder, this number is a lot higher. So estimates show that over 75% of persons in treatment for opioid use disorder smoke cigarettes. And then that might be even higher for individuals that are not in treatment. So among persons who use heroin, it's been reported that it's as high as 92%. And then among participants in syringe exchange programs, it's been reported to be as high as 95%. And this is higher compared to other substance use disorders. So we looked at that a little bit last week too, compared to alcohol. The rates of smoking are even higher with opioid use. And so the take-home message here is a lot of people with opioid use disorder in treatment and not in treatment smoke cigarettes. So I've got our first poll question here, and this is anonymous. We're not going to put names up here or anything. If you feel comfortable answering this question, we would appreciate the information. If not, you absolutely do not have to answer it, but just want to get a little bit of a feel for how many people currently smoke, if people are former smokers or have never smoked. And I will put myself somewhere in between the former smoker and never smoker category, because I've had some periods in my life where I smoked on a semi-regular basis, but never really considered myself a smoker. So I'm kind of in between those two. So we've got a pretty good mix there. Okay. So we did have a question about smokeless tobacco. The presentation last week did focus on cigarettes, and we talked a little bit about e-cigarettes and vaping last time, but smokeless tobacco is still a source of nicotine. It's not I don't think as big of a problem with this population as smoking is. So if you look at this chart, this is the percent in the United States among the general population. So you can see cigarette smoking is much higher than the other forms of tobacco or nicotine. So smokeless tobacco is only 2.4%. This is for the United States. So like with cigarettes in Kentucky, it's a little bit higher. So estimates from 2017 for adults in Kentucky, it was 7.6% use smokeless tobacco. So it is a little bit higher here than it is, on average for the country. So there doesn't seem to be as big of a relationship between smokeless tobacco and opioid use or opioid use disorder. So the 2011 National Survey on Drug Use and Health showed that, like other information, the odds for current cigarette smoking were increased for alcohol, cocaine, heroin, and marijuana use. So there was a relationship between the use of those substances and cigarette smoking. But for smokeless tobacco, the only time that the odds were increased was with alcohol dependence. So there wasn't really that same relationship with illicit drug dependence and smokeless tobacco as there is with illicit drug dependence and smoking cigarettes. Next slide. But if you are working with someone that is using smokeless tobacco, we should still talk to them about that and try to encourage them to stop, because it still contains nicotine and there are risks associated with this drug. It increases the risk for heart disease and stroke. It can lead to addiction. So the drug itself is still reinforcing and can still lead to addiction. And many times, even though it doesn't start out as smoking, people that are addicted to nicotine can progress to smoking cigarettes. And then there are some still going to be some issues with pregnancy and in delivery. And then specifically for this form, there's a risk or a higher risk for cancer of the mouth and esophagus, and it can lead to gum disease, tooth decay, and tooth loss. Does anybody have anything that they want to add about smokeless tobacco before we move on? Okay. So we also talked last week about the relationship between tobacco, nicotine, and chronic pain. So 24 to 82% of persons with chronic pain currently smoke. And we know that people who are dependent on nicotine are more likely to develop chronic pain. It was a risk factor for fibromyalgia and back pain and migraine, so a lot of chronic pain conditions. Nicotine dependence is associated with initiation of opioid analgesics, chronic opioid use, less decline in opioid use. So say if someone starts an opioid after surgery or for back pain, something that in a lot of cases would be acute use. So it would be, 3 days to a week's worth of medication treatment. People that are smokers are going to be more likely to stay on that medication longer and not decrease their dose compared to non-smokers. And the nicotine dependence was associated with high dose opioid analgesic use. And we know that there are risks associated with high dose opioids in chronic use. So there can be the risk of progression to opioid use disorder. We also talked about the drug interaction with smoking and opioids, and that may explain the high dose opioid use because when people are smoking cigarettes, they're going to metabolize the opioid faster. So it's not going to stay around in their system as long. So they're going to be able to tolerate higher doses, or if they're treating pain, the same dose may not have the same effect as it would in a non-smoker. So because their body's getting rid of the opioids faster, they might need higher doses to achieve the same level of pain relief. So you can go on. So I mentioned this last time and said we could think about it and talk about it this week. Should smoking status be considered when we're prescribing opioids to patients? So it looks like people are leaning more toward yes. 77% of our audience today said yes. So did anybody that answered yes, do you want to give any reasons why or what you think that we should be doing with smoking and opioid prescribing? So something that I thought about this, if we know that people that are dependent on nicotine are more likely to progress to chronic use, should we start out with alternative treatment options first before opioids are used? That's one way that I looked at it. And then kind of the flip side of the coin, if we know that people who smoke are going to be metabolizing the opioids faster, does that mean that they should start at a higher dose? Because they may not achieve the same effect with a lower dose as somebody that wasn't a smoker.
One thing that I thought of, and I don't know anything about this really, so it's just a guess, would be like shorter prescriptions and more check-ins to make sure that, like the treatments are effective. And if it's not effective, then, changing treatment options. So just, fewer amounts and more check-ins.
Yeah, that's a good point. Last week, we talked about kind of a progression from adolescent smoking to having chronic back pain, which led to hospitalizations, which led to initial opioid exposure. And then this population was at a greater chance for opioid use disorder. So if we could check in at different kind of parts of that progression before it got to chronic opioid use and then opioid use disorder, then maybe there could be interventions made along the way. Okay, we can go on to the next slide unless anybody has anything else to add. So we talked about risk for smoking and nicotine last week and talked about some of the health-related risk. And this is just for anyone who is a smoker. There are 16 million Americans living with smoking-related diseases. Cigarette smoking causes more than 480,000 deaths each year. Smoking causes about 90% of deaths from lung cancer. It causes about 80% of deaths from COPD. And then these patients are at increased risk for coronary heart disease and stroke. Next slide. We also mentioned that it's not only related to lung cancer, but is a risk factor for many other forms of cancer in other parts of the body. So this picture shows all of the different organs or organ systems that might be involved. And you can see that it's a lot of different body parts here. And then specifically related to individuals with opioid use disorder, the quality of life seems to be poorer compared to individuals that are only dependent on nicotine or smoking. The effects for babies, so birth weight and severity of neonatal abstinence syndrome seems to be higher in individuals with OUD that smoke. There is a risk of premature mortality, and this seems to be even more pronounced for this population than individuals who are only using tobacco. So the rate of death from tobacco-related causes and opioid use disorder is twice that of the general population who smoke. All right, so take-home message, there are health risks associated with smoking cigarettes. And I hope that we can all agree that there are substantial risks there to anyone's health. So we also talked about smoking cessation and why this is important. As far as brief behavioral interventions or brief interventions, we talked about the 5 A's. So this was asking the patient if they use tobacco, and this included the form of tobacco, if there have been any changes in their tobacco use status. For cigarette smokers, how long it is till their first cigarette, because we know that that can be an indicator of nicotine dependence, how dependent someone is on this drug, and it can also be a predictor of success in treatment. We should advise patients to quit and try to make this specific to the patient. So thinking about their other health conditions or things that relate to their treatment and recovery, just anything to make it really relatable to the patient. And then the next A is assessing willingness to quit. And we talked about some of the different phases of readiness to quit. So some people just aren't ready. Some people may be thinking about quitting. Some people may, be in the process, have a date set. They may be thinking about doing it in the next month. Some people may have quit recently, and then some people may be former smokers. And based on what stage that they're in, that is the assistance that would be provided to them. So it will be based on their willingness to make a quit attempt or where they are in that quit attempt. And then we would also arrange for follow-up. So kind of track progress, see if there are any roadblocks that people are facing, if they're doing well, if there's anything that they need, just to hold them accountable also. For behavioral interventions, there is a telephone quit line available. There's one in each state, and here's the website for Kentucky. we have to keep in mind that in a population that may not have stable phone access or stable access to a computer, this might not be the best option, but it is something that's available. I did try to get in touch with them and see if they had any resources that were specific for individuals with substance use disorder or opioid use disorder, but I just kind of got a kind of a standard response. So nothing very helpful, but this is something that is available and it's free. And it did mention that some people might be available or might be eligible for free nicotine replacement therapy products. So it looks like it's not just based on the behavioral aspect here, but they help people get nicotine replacement products as well. So one thing that I didn't put a slide in here, but I wanted to try to ask if we have quit lines or internet options available to help with the behavioral side of smoking cessation, and people don't have maybe consistent telephone access. Are there ways that we could help people connect with these things to help them with treatment, since there do seem to be a lot of online options available?
What about having something at, if the area has like a local library or something that people can come to maybe weekly or something like that?
That's a good idea. Okay, we can move on to that next slide, John.
Okay. Just in the chat, Lisa said faith community groups.
Okay, yeah, that's another good idea. So we talked about the medications that are used for smoking cessation last week, and there are 7 different products that are approved by the FDA for use in smoking cessation. And most of them are nicotine replacement therapies. So it's a product that's providing a source of nicotine that doesn't come from tobacco. So people are able to manage their withdrawal symptoms while they're focusing on behavioral modification and slowly decreasing the amount of nicotine that they're putting into their bodies to make the withdrawal process a little bit easier. There are different forms. So there's a lot of options for patient preference if they would prefer a gum or a patch, or if adherence is an issue, which it is with a lot of medications and just kind of the general population. Patch might be better because it's put on once a day. There are a couple of non-nicotine products that are approved for use. So bupropion, which is an antidepressant, more commonly known as Wellbutrin. The brand name for the product that was specifically approved for smoking cessation was Zyban, but I haven't seen that name around in a really, really long time. It's mostly the generic medication now that's dispensed. And then varenicline, which the brand name is Chantix, that's the newest one that's available. And we talked about how this one works kind of in a different way. It is a partial nicotinic receptor agonist. So we talked about how that was similar to the way that buprenorphine works. And from this chart, this isn't a study that looked at all of the different drugs and compared them together. This was information from a lot of different trials that they just kind of put together to have not really a comparison, but really just to show that all of the products are successful. They are effective as compared to placebo. So there are a lot of good options that are available, and people can have success with any of them. And if one doesn't work, they can try another one because there are other products available. So does anyone have experience with any of these products that they would like to share, or any questions about any of these products while we're here?
So are these products the nicotine replacement, because I know that the nicotine from the cigarettes and the vapes are harmful to the fetus. So what about the nicotine replacement products? Like, are them, could them still have the same effects as, say, like cigarettes would have on a pregnant woman?
So
Am I
yeah,
saying this right?
yeah. Would probably want to start with more behavioral modification in somebody that was pregnant. And that's one of the categories where it would take some special consideration to pick something for somebody that was pregnant. And a lot of times it's kind of weighing the risk and the benefits for the mother. So it's not something that you would want to treat over the counter. That would be something, a population that would need to be under the care of a healthcare provider for smoking cessation.
But I would say that, yes, there's nicotine in gum and lozenges and patches and such, but overall, it's a lot safer than combusted tobacco or chewing tobacco, in terms of other carcinogens and that enter the bloodstream, and may affect fetal outcomes. And so ultimately for a pregnant person, the goal is to stop smoking. And if that's best achieved by using patches, gum, lozenges, and then tapering those, that is safer than, because some people, I mean, they may try really hard to just stop cold turkey, but that's very unpleasant and it's difficult, and some people really struggle with it.
Thank you. That was very helpful. So for patients with opioid use disorder, does anybody have an opinion as far as which one you think would be the best choice or the most acceptable?
I feel like the buprenorphine would be the most acceptable, just because I was a smoker and I still sometimes struggle with that. But I think that it's like the sensation after the use, like, that is satisfying, that somebody wants to go and have nicotine right after using a substance, alcohol or opioids or whatever. And so I just feel like the buprenorphine, as you take that daily, and it's just kind of like the behavior modification just kind of comes on in without you even noticing it. I don't know, it just kind of goes away in its own little way, and then you look up and you're not smoking one day. It just kind of creeps in and helps ease the cravings. So I think that the buprenorphine, is that how you say it? The Wellbutrin?
Yeah.
I think that's a really good option for people with OUD. And it also, helps with the, depression and things like that. So, it's kind of a double whammy in some ways.
I think that's a really good point to note, that it does help with depression that may be linked to the smoking too.
So just it's a little tricky. The two medicines, the generic forms sound pretty similar. So buprenorphine is Suboxone. Oh my God, same thing, right? Bupropion. There you go, is Wellbutrin, which is what we're talking about here. The antidepressant that has some benefit in smoking cessation.
And to add to the confusion, it has different brand names. So
Zyban, right? Is that the one for?
That was the one that got the official approval, and it was the sustained release form. So there is an immediate release Wellbutrin, the Wellbutrin SR, which is the same as Zyban, and then Wellbutrin XL, which is a once daily formulation, but doesn't officially have an indication for smoking cessation. I don't know if it's been tried for smoking cessation. You know, it's the same generic drug, it's just a different release. So I don't know if there is success with that, or if there's something special about the sustained release formulation, or if that's just the one that they did the trials in.
I don't prescribe the one that was for smoking cessation, labeled specifically for smoking cessation. I prescribe the once daily one most typically because people are more likely to take a once daily medication. I don't know if it's helpful, but the way I talk through with patients their options is really to frame it as what are you most likely to, the medicine that's going to work is the one that you're most likely to take. And so, and the one or the device or that you are most likely to use. And so I talk through all of the options. Varenicline Chantix has, as the previous slide shows, has the most data for being effective. And I explain that. We talk through the side effects. It of course is taking a pill twice a day. In terms of the nicotine, the other nicotine products, patches, gum, lozenges, the inhaler, I usually show people pictures of what they are and talk about like what they like about smoking and which they might enjoy more in terms of what do you like to have, gum or a lozenge? Do you really like holding something in your fingers, recognizing that this doesn't feel like a cigarette, it's like a little plastic thing, but you can hold it. The fastest way to get nicotine into your brain for a really bad craving is actually the nasal spray, but some people really don't like spraying something in their nose. So, and it burns. So I usually say, you know, these are the options and what do you think is most likely to work for you? And sometimes people try one thing and they're like, oh, I couldn't stand the taste of it, or I really liked XYZ, and then we might try something else. It's not, the nice thing about the options to help people quit smoking is that there actually are a lot of options, and you can kind of trial it with people and see what's going to be most effective for them.
Yeah, it's good to have a lot of choices just so, you know, patients' preferences can be taken into consideration. And if you all are talking to patients that use tobacco or smoke cigarettes, you don't have to try to memorize all of the different dosage forms or all of the dosing, anything like that. I've got a few resources that I'm going to show you to help you kind of go over the different things with patients, and so you can communicate with them and help them make treatment decisions. So you can go on to the next slide. So I'm actually going to share my screen on this one. So this was something that I found that the CDC had that I thought could be a useful tool. So it kind of broke down into nicotine replacement therapy and then the other forms that are non-nicotine. And if you click on each one, so if we click on the nicotine gum, it kind of gives you a list of pros and cons. So you can go through some of the things that people like about this kind of product and some of the things that they may not like. It gives you a list of the side effects, and then, like we talked about last week, some of the precautions with the different forms of nicotine replacement therapy. So another feature on this website, and I can share this with everybody, the medicine tips for you could be helpful if someone wants information about like how to decide, you know, they're thinking about quitting, or maybe ready to quit and they want to try medication, there are some questions here that can help them make those decisions. So it asks, how much do you smoke? And then based on the number that you pick here, it will give you kind of a little information. So for this one, it says using any of the approved medications could work for you. And then if you're looking for something that is simple to use, you might consider the nicotine patch. Like I said, this gets put on once a day, and then you don't have to remember to take anything else or have anything with you, or one of the oral forms, the pills, versus the gum or the lozenges that have to be used or might be used multiple times a day. So I thought that was useful if you had access to a computer and somebody had questions about maybe finding the right thing for them. Okay, John, you can share the slides again.
Will you be able to share that link that you had, or do I just?
Yeah, I'll put it in the chat.
Okay, thank you.
Chris just put that link in the chat.
Thank you.
Okay, thanks.
So on the next slide, the FDA has a brochure. I didn't like this one quite as much. It has kind of all of the same information, but it's more in paragraph form, so it wasn't as easily digestible. Next slide. Okay, so the American Academy of Family Physicians, I found a resource that they had put together on pharmacologic options for smoking cessation. And I know you all can't see this, it's really small, but I liked that it was in a table and you could kind of compare everything side by side. So it had information about the product that was available, what flavors it comes in, the precautions, the pros and cons. It had information about cost. You can go to the next slide. So I took the information from one of the columns and made it bigger so you all could see what was in this comparison chart. So it has the different names for the product. This is the transdermal patch. So it's Nicoderm CQ. It comes as different generics. Like I said, there are precautions listed, the dosing, and it's recommended based on the number of cigarettes per day. It has a few tips on using the patch, the adverse effects that are possible, and then again, kind of the pros and cons of each dosage form. And I like having things kind of all in one place so I can compare them beside each other. And we can get this to you as well if anybody is interested.
Chris put it in the chat again. He's very good at links.
Okay. And then from smoking cessation guidelines, there are kind of some questions. If you're helping somebody make a decision about what they're interested in or what they want to try or what might be best for them. Again, thinking about, what should be considered. And then some of the patient factors that would help make decisions. So if somebody is a lighter smoker, lower doses might be better. There are certain products that might be better if somebody is concerned more about weight gain, if they have a history of depression, if they have a history of cardiovascular disease. There was a precaution with nicotine replacement therapy, but it doesn't mean that it can't be used, just that it needs to be used carefully. And then some other things to think about up in that second line, what factors should be considered. The familiarity with the medication, if there are any contraindications to taking it. So if there's any underlying medical conditions or comorbidities that would be dangerous with a certain medication, like with bupropion, it can increase the risk of seizures. So if someone has a seizure disorder, you wouldn't want to recommend that for that person. And then patient experience is something else that is good to ask about. So a lot of people, it takes multiple quit attempts to become a former smoker or to have longer successful periods of abstinence. So if somebody has tried something before and it worked, that might be something to try again. Or if it didn't work, maybe pick something different the next time. And then something else that I didn't talk about last week that comes up, and it may be useful for individuals with opioid use disorder, is combination nicotine replacement therapy. So you can use a nicotine patch, which gives like a controlled release of nicotine throughout the day, with the gum or nasal spray, something that gives you kind of a bolus of nicotine to help with cravings. If there's a certain time of the day that somebody knows that they usually smoke, that their cravings might be higher, they could use a patch and then use something else during certain times of the day. And we know that people with opioid use disorder seem to have higher dependency on nicotine. Okay, so we did have a question last week about cost and if that was a barrier to treatment. So I wanted to provide a little information on the cost of smoking. And this would be how much the treatment would cost per day for someone. I'm sorry, the cost of smoking cessation. So, there's kind of a range here depending on what the product is. Most of the newer products, so Varenicline is over $15 a day. The nicotine inhaler cartridges, that's a pretty new product and it's almost $15 a day. And this isn't the maximum dose. So with the gum and the lozenges, use can be more than 9 pieces a day. So I think for gum, it's 24 pieces is the maximum. And then, 24 for the gum and then 20 for the lozenges. So it could be more expensive than this, but a lot of them are still less than a pack of cigarettes. Next slide. And then, does Medicaid cover medications for tobacco cessation? Yes. All of the drugs that we've talked about are on the preferred drug list. It doesn't mean that every brand of nicotine is covered, but there are lots of different options for smoking cessation that are considered preferred drugs. There are quantity limits. So, it may be only a certain amount per fill. I tried to find information to see what the limit was specifically, if it was, how many you could get at one time or how many that you could get in a year's time period. Sometimes quantity limit means different things, but there may be limits on how many or how much of these products that you can get. And then there was an age limit for Chantix. So it may not, or it wouldn't be used in adolescents. Any questions about coverage for these products or the cost or anything? So back to our review a little bit. We talked about smoking cessation in patients with opioid use disorder, and some good things is that the interest and motivation to quit would seem to be the same as the general population or very similar, and that most of these patients have made multiple prior quit attempts, which can be an indicator of future success, and the patients are willing, but they may not be receiving offers, or people may not be talking to them about their tobacco use. There are gaps in the evidence, so we don't have as much information about how treatment works as we do in the general population, just because these patients would have been excluded from the clinical trials. And then treatment can be challenging, and like with most people, adherence to medication is an issue. Okay, so another poll question, and this is something that's kind of under debate. When should we talk to people about their tobacco use? Should it be addressed at the same time as their opioid use, or should it be sequential? So maybe after somebody is in treatment and stable, should we then talk about tobacco use? And I forgot to make a note that I've put in some vintage tobacco and cigarette ads just to make it a little more visually appealing. I'm not promoting these products in any way. I just thought, it's kind of funny to look back and look at the promotion that cigarettes used to get and kind of think about, now are there products that are being advertised that, in 20, 30 years, we'll look back on and think, oh my gosh, I can't believe that we thought that that was okay. But the ones with the doctors and the nurses are pretty concerning. All right, so we're getting a kind of an even split on the question here. So does anybody want to talk about why they think one or the other?
I think it should be kind of gradual because they're already overcoming so many barriers, and tobacco use is usually ingrained into their culture. Like, I'm from Eastern Kentucky, and I remember like my papaw, like literally, like he had like a tobacco farm. And I think my brother has actually been chewing snuff since he's been like 12 years old. So gradual, you don't want to overwhelm them with everything, but if they're open to it, like a lot of these options I didn't even know were available until this, so I'm really excited to utilize these. I'll definitely introduce them, but whenever they're ready, I'll give them everything. So.
And that is part of the discussion. People are afraid of being overwhelmed, and the people that are working with these patients are afraid of overwhelming them too. So that is a very common opinion. Where are you from in Eastern Kentucky?
I am I call it Ashland. It's like the tri-state area.
Okay.
So a little bit of West Virginia, Ohio, and Kentucky. But these are all really good resources and easy for people to access on their own too. So I think just at least giving them like the links and stuff and going over it lightly. That's something I'm going to start implementing because it's most of the people I've worked with that have opioid use disorder definitely smoke. So.
Yeah, I agree with Whitney. I think that it should be introduced gradually because whenever you do first come into recovery, you are so focused on not slipping or lapsing. And, that cigarette to some people actually helped them in the beginning to kind of steer away unbelievably. And it's kind of a coping thing in the beginning. So I think that introducing stopping smoking is gradual because I was in recovery for 2 years before I then started like, all right, I got this I got this under control, I can do this. So now let's start with the cigarettes. I've got my opioid use under control, so let's get the nicotine. And then that's kind of how I did it. I then started working on that because it's one thing at a time so that you don't get overwhelmed and set yourself up for failure.
So anybody that voted for concurrent treatment want to add their 2 cents? Well, I'll say one thing that I think would be important with talking about it at the same time or trying to address it at the same time is just so you don't miss an opportunity. So if someone doesn't return, drops out of treatment, then you've not missed that opportunity to talk about their tobacco use.
I think too, once people are a little bit more stable, and they're holistically like working on things like their physical health and well-being too, that they would be more open. Maybe if they're already like on a good track, like maybe start with some harm reduction things. But yeah, this is all really cool information. I'm excited to share this stuff with people and my friends too, just so they can utilize it as well for their patients and clients.
Good. Thank you for that feedback. Okay. One other thing, some research has shown that people who treat tobacco dependence and opioid dependence at the same time, there have been some benefits there. So there have been some studies that show that people may stay in treatment longer or recovery is longer. So that is one reason that, there's kind of a debate here that, we have some evidence that shows that there's an association with working on tobacco use at the same time with good outcomes, but also the risk of opioid use is more imminent. And, in the short term, there's a risk of overdose. So we want to focus on that problem first and not overwhelm the person with too much information all at once. So there's, some information about both sides there. So we can move on now. So we talked about some of the barriers last week and some that were more specific to this population. So this was from the study of hospitalized patients, where they compared the acceptance of counseling and nicotine replacement therapy among individuals that didn't have a substance use disorder to people that did, and broke it down by alcohol use and opioid use and cocaine. And even though more people with the substance use disorders were smokers, the level of acceptance for the counseling and the nicotine replacement was pretty similar. And it showed that there was interest there. But they did interviews with some of those people and found that some of the barriers that they faced was the exposure to tobacco, lack of health professional support. They didn't have a lot of concern about their health when they were high. They were afraid that it would affect their sobriety, that heroin increased their cigarette cravings. They needed to work on the other substances first, and fear of being overwhelmed. And they didn't really feel like, they realized that there were negative health consequences, but they didn't really feel like it applied to them as much. Next slide. And then other barriers that have been mentioned in literature is just the burden of having a chronic disease, which opioid use disorder is a chronic disease where you have to deal with appointments and taking medication daily and trips to the pharmacy or the methadone clinic, things like that. Psychiatric comorbidities, and smoking is higher in these populations too, and that includes a different set of barriers. Psychological distress, cue-induced cravings, so just the cues of taking an opioid, even if it's part of treatment, can induce cravings for cigarettes. And it seems like evidence points to the pharmacotherapy being less effective than in the general population. And then there is kind of a culture that is accepting of cigarette smoking in this population. So some things to think about with that is the training of the treatment staff and the attitudes of staff, and then the amount of social support that these people are receiving. So can anyone add to the list of barriers? We didn't really talk about kind of the general barriers that are faced. A lot of people cite weight gain. That's one that people worry about a lot, or how they're going to deal with anxiety without smoking, or any things that you can think of that might be ways to overcome the barriers that were listed. We can think about that. And if anybody comes up with anything they want to throw in later, we can come back to this one. Okay. So we talked about kind of the culture and it's accepted. So I wanted to ask what you all thought about treatment facilities being smoke-free, because that has been proposed as a solution to overcoming the kind of the culture of smoking and just being around people that smoke more and maybe feeling that it adds to your social interactions. And if you weren't a smoker, then maybe you would be excluded from those interactions. Okay, so mostly no. So why don't we want to make facilities smoke-free?
For me, I think it would be a deal breaker. Because I'm a person in recovery and I just don't think that I would want to go to a rehab where I couldn't smoke cigarettes if that was the only thing I had left to make me feel almost okay or take away a little stress. I personally think it would be a deal breaker.
And you're not the only person that thinks that. That's the reason that many facilities that don't encourage smoking cessation cite that they feel like if they try to talk to people about not smoking or not let them smoke, then people won't want to come there.
Yeah. There was one place I went that had in Louisville that had like limited smoking. Now maybe that would be a better option than automatic just getting rid of it altogether. But like there, we couldn't have a lighter of our own. We had to go out at certain times, and it was like a reward system. So like if we went to group and class and stuff, then we would be able to go out and smoke.
Okay, that's something that I hadn't really thought about with this or read much about. I'll play devil's advocate here. Do we want to make smoking a reward though? If we're thinking about individuals' health.
Maybe not a reward, but if I was in a rehab and they said that the only way that I could get to smoke was to attend group, then I would.
That would definitely be an incentive.
Yeah.
Yeah.
I forgot what that kind of therapy is called, where you get I think we had a KY open on it a couple of weeks ago. I forgot exactly what it's called, but it's like basically like if you get something for going to group or something like that, like at like candy or some things. I forgot exactly what it was called.
Anybody else? Okay, and you know the smoke break is a part of it that is addressed in kind of thinking about should facilities be smoke free. You know, if that's seen as a reward or if that's your social interaction time, instead of having it called a smoke break, take a walk break, or calling it something else so it's not being encouraging for smoking. All right, so we talked a little bit about e-cigarettes and vaping. There aren't as many people nationally that use these products, but it is prevalent among substance use disorder and then the dual use. So using electronic cigarettes and traditional cigarettes is common among this population. It's seen as less harmful by everyone, and it's perceived as being helpful with not smoking. So it's not an approved product for smoking cessation, but some people believe that it can help them stop smoking. And then there have been sort of mixed findings about whether this is true within this specific population. There are, risks associated with inhaling liquids and chemicals into your lungs, and it's another source for nicotine. So it's used a lot in younger populations. And that's why I'm not as familiar with these products, because it's increasing in kind of the 18 to 24-year-old age group. But it's introducing people to nicotine that weren't smokers, and that addiction to nicotine could lead to future cigarette smoking. Okay, so if we're thinking about harm reduction for a lot of different things, is harm reduction possible for cigarette smoking? And what would that look like if we're thinking about vaping?
I think handing out, or, you know, like going to places and setting up and having like little bags with information about the vaping, the harm that it causes, and then having options of what they can choose to help get off of the vaping, maybe.
And can you all think of any ways that would make tobacco use or cigarette smoking less harmful? Like, does anybody have any thoughts about that?
I think they have like cigarettes that aren't really tobacco, like American Spirit or something like that, if I'm not mistaken, that are like smoking. I don't know for sure what it is, but maybe less tobacco, I guess.
Like the healthy cigarettes or something like that that's coming out with yeah, I've seen them that's coming out. Or like what about the hookah? Like is they make it seem like the hookah thing is not the same thing
Yeah.
as
American
So
Spirits are hardcore. Those are like,
Are they?
yeah. Oh my
I'm not
gosh.
familiar with them.
I think it
they're
has like less
natural.
to make. Yeah, it is natural, but I think
Yeah,
I
there's
thought
probably less carcinogens, but the
yeah.
tobacco is still there.
I think it's like less nicotine and stuff too. If I'm not mistaken. I don't know for sure. Somebody told me it was healthier.
So unlike when we talked about alcohol, there's not really a safe threshold for cigarette use. So there are thoughts about lower nicotine cigarettes. If that would be helpful for people, we'd still be getting something burning going into our lungs. And I think a lot of people believe that vaping is a safer choice than cigarettes.
But in the
But
long, it's
I'm sorry, go
unhealthy.
ahead, Gary.
It's unhealthy too, though, right? If not worse.
There are risks. It's not the same as cigarette smoking, but there are chemicals that there can be carcinogens that are being inhaled. And one of the biggest issues is that a lot of people that are using vaping for smoking cessation aren't completely stopping the cigarettes. So they end up using both. Not everyone, but some people end up using both.
Yes, I was that person at first when I tried to quit. I was using both.
So did you ever get to a point where it was just the e-cigarettes?
No, I
Okay.
actually dropped back down to just the regular cigarettes because it was just so much of a hassle at first. But mine was before all this new stuff came out. Mine was when you had to go buy the liquid and put the liquid in. And
Okay.
now they just got the pen you can just buy in the store and push a button.
Yeah. All right. So anybody else have anything they want to say about this topic before we move on?
I just Googled and they have like herbal green tea cigarettes that contain no tobacco and no nicotine. So I think that would be something that could be used for harm reduction. If someone was interested.
I think going into the schools, because I know they say that they cannot purchase tobacco until what, like 21 now, I think, nicotine products. But these kids are getting these vapes in the schools and they're starting very young because of the flavors. And I just feel that if we could somehow get into the schools and start talking to the children young, just how they have, the sex ed classes and things like that, I really think that they should start having a little bit of this in the school to talk about also.
That is a good idea. I have a friend who is a high school chemistry teacher, and he got a lot of pleasure from catching people vaping and taking their vape pens in school, and trying to educate his classes about, what happens when you heat up chemicals, they change, and, you're putting these things in your body. So I think it is a problem in schools, and I'm sure the flavoring is not helping with that. And we are seeing increases in use in that younger age group. So that is a really good point.
But
Okay.
I think, real quick, sorry, personally, that alcohol is a gateway to cigarettes. And I think with the younger people, like teenagers and things, like they're more likely to probably engage in alcohol use before they engage in like drug use of any sort. But cigarettes are just so easily accessible to, like whenever you're a teenager. But yeah, and a lot of people just smoke when they drink. So I think alcohol is the big no when it comes to cigarettes, but also like with substance use disorder as well. But that's a whole different topic. But that's what I've always thought, that cigarettes and alcohol, like that weird correlation.
There is definitely a connection. It doesn't seem to be as high as it is with opioids, and there's a little bit of a difference there, but it is definitely higher than the general population. And I think education for younger people on all of those things would be really helpful. So before we run out of time, let's talk about some other resources that could be available. So I mentioned this last time and just kind of touched on it. If you search for smoking cessation, a lot of different things come up. So there's a lot of information online. There are a lot of resources. So the CDC has some good information. RX for Change is one if you need continuing education, or if you wanted to give a presentation about smoking. They have a lot of slides put together. We can go to the next slide. So I wanted to kind of poll you all and see if you knew of any resources that were available in the counties where you work, or if you're a former smoker, what has helped you. And I learned something when I was looking for pictures for the smoking ads, the vintage smoking ads. Pez was designed as an alternative to cigarettes. So it may have been the original smoking cessation product, and I did not know that.
It's interesting.
So I tried to find a little bit for Fayette County. The health department may be a good place to start. Fayette County's health department did have information about smoking cessation resources and possibly getting help with paying for nicotine replacement therapy on their website. The Kentucky Clinic Pharmacy listed smoking cessation as one of their services. I don't know to what extent. It didn't have a lot of details about what they provided, but that was something that they listed. And then UK's Salvation Army Clinic also listed smoking cessation as one of their programs. So those are some things that I found for Fayette County. And I don't know if it's because there are apps now and online resources, but it didn't seem like there were as many in-person resources as I expected. Okay, So another question that we got, what recommendations do you have for peers and care navigators working with clients with opioid use disorder who also use tobacco? So this isn't from like an expert resource. This is just kind of my opinion for what I think. I don't think you have to be an expert in smoking cessation or any of the medications you use to start a conversation. You can use the 5 A's. So at least asking about tobacco use and advising individuals that they should think about quitting and seeing where they are in that thought process, assessing them, and then offering help depending on the phase of readiness that they report. I think it's important to be honest with people. You know, this is something that is challenging. Nicotine is highly addictive and it's going to take some effort, but you also at the same time don't want to be discouraging. So we probably don't want to start out with, you know, the medication is less successful in individuals with opioid use disorder, opioid use compared to other populations, or that the quit rates are lower for people with opioid use disorder or who misuse opioids. We may not want to share things that would be discouraging up front, but still acknowledge that it is a challenge for people. So, and keep asking. So if you have encounters with individuals and they may not be ready to talk about it the first time you ask, but if you see them again, keep asking, because it might be, you know, the 5th or 6th time that you bring it up. They will want more information, and try not to miss any opportunities that you have to bring this up if you know that somebody is using tobacco. And remind them that health and wellness is part of recovery, and that smoking cessation is something that can definitely improve health and wellness. I thought something that might be specific for this population versus the general population, if someone is using buprenorphine, it might be helpful to compare it to Chantix, the way that it works. So if they're taking buprenorphine and have seen positive outcomes based on that, and they know that this drug works in a similar way, that might be something that is encouraging. And try to make the conversation specific to treatment for opioid use disorder, because we have some information that shows that it is linked to positive recovery outcomes. And then let's see, does anybody have anything else that they would want to suggest? Like I said, these were just kind of things that I thought of. See, I do have a quick video. John, do we have time to show that?
Yeah, we should have time.
Okay. So this is just an example from Quit Now, Kentucky of, they don't use the 5 A's there. It's 2 A's and an R. So an example of how this would look when you're talking to somebody.
Let's see the 2 A's and an R in action. Mr. Smith has come into the clinic for care, and I've noticed in his chart that he has high blood pressure and high cholesterol. So today I'm going to interact with Mr. Smith about this.
Is it not working?
We can hear it, but we can't see it.
I can't see it.
You may have to stop and reshare.
All right.
That's why I didn't want to do this, because I knew that I usually can get the video, but I can't get the sound. There we go.
Hi, Mr. Smith. How are you today?
I'm well. How are you?
I'm doing well. I wanted to talk to you about something I noticed in your chart. I noticed that you're having high blood pressure and high cholesterol. So I wondered if I could ask you some questions about that.
No, that's fine. Go ahead.
Okay. Do you use tobacco?
Actually, I do. I smoke about a pack a day.
Okay. And how long have you been a tobacco user?
Roughly 10 years.
Okay. So it's been something that's been a part of your life for a while.
Yeah, you could say that.
Okay. I'm wondering what your future plans are with tobacco.
Well, I really haven't thought about quitting anytime soon, so I guess I would continue to smoke for now.
Okay. So you talked about not quitting soon, but it's something that maybe you've thought about in the past?
Well, I have tried in the past, I mill it around, and, at this point, it's something I'm not really ready to take on.
Okay. Okay. So it's something that you've even attempted in the past, but today you're not quite there.
That's right.
Okay. So I wondered if you would be open to me sharing some information that you can take home and review, and then when you come back for your next visit, if we can continue that discussion.
Yeah, that's fine.
Okay. So as we walk out today, I'll hand you that information and you can think it over and ask me any questions the next time we see each other.
Yeah.
Okay.
Let's do that.
Great. As you can see, Mr. Smith is not ready to quit, so providing him a referral to the quit line would be an inappropriate intervention. If he was ready to quit, I could provide him a referral directly to the quit line, or I could provide him the information where he could reach out directly to the quit line.
So that's just an example of how a short conversation could work, and it took about 2 minutes. So I wanted to share a few more resources that I thought were helpful, and we'll put links to these in the chat. And if anybody would like the PDF, we can send that to you as well. The Implementing Tobacco Cessation Programs in Substance Use Disorder Treatment Settings from SAMHSA. I read through this one and I thought it was good because it gave a lot of specific information that related to opioid use disorder. So it made it really relevant to these individuals. So I liked a lot of that, and it was a pretty short. I think it was 16 pages with references and everything. And it did have a lot of resources listed in the back. Most of them were national and a lot of them were online things, but it did have some other places to find information. So I thought that was good. And then as part of their toolkit, they had a couple of brochures. There was one specifically for patients. This one in the middle, you can quit tobacco. So this is something, it's just a folded brochure, so it's easy to show to people, and it has a small amount of information that you could go over in a quick period of time. And then I found another one that was specific for substance use disorders. This was from a group in Colorado. It was much bigger. I started to print it out today and realized it was 42 pages, and I decided not to do that. But it had more details on all of the medication options and behavioral interventions, the 5 A's, what went along with that, examples for things like that. So it was something else, though, that was specific for this population with substance use disorders and tobacco use. So we can provide these, like I said, if anybody wants a PDF. Just something that you can have to be able to pull out some information to share with people as you feel like it would be useful.